So Santé Publique France has decided to see what was happening with people who weren't working in the agency, what they thought about what ethics in public health would mean. Next slide, please. So what is a consultation? It's a form of expertise. It isn't work itself with qualitative research, but it's trying to take stock of the current situation to see if there is consensus or discrepancies amongst a group of people deemed to be experts in public health. It isn't a methodological approach, it's sequential. There's no... This is really sequential and different iterations which correspond to the adaptation of the interview guides that we've made, depending on the different topics talked about in the workshop. So for each workshop, we had specific questions, but essentially, the interviews were free and not structured. We tried to structure them as loosely as possible, even if we had planned second follow-up questions. So next slide, please. We can see from here this organization chart with each contact point. So you needed at least a day to get an appointment. It was quite long. I mean, it lasted a whole year with 40 participants, not 45, Jean-Claude. You're overestimating the work. I reached 40, which was already pretty good. We had a good rate of acceptance as well. We had secondary interviews as well. And what I thought, and we'll get to this quite quickly, but what was very striking is I got a lot of phone calls from experts saying, are you sure that I'm the right person? I don't really know what ethics in public health is. I'm quite scared. And I said, well, no, it's between you and me. Nothing will be sent to Santé Publique France. So there's always this judgment, this over-evaluation of the role of Santé Publique France as being a body which may sanction people or to be a guarantor of morality. And so I said, no, it's between you and me and nothing will be sent to Santé Publique France. Therefore, its trustworthiness is quite important. So next slide, please. So we wanted representativity. So we looked everywhere. What we really wanted to do was to get people who were outside of Paris, mostly North America and Europe, but I also wanted to set up people from emerging countries in the south. I work a lot with Africa as well. So this is about all professionals in North America, in Europe, in Australia, but also in other countries, namely in Africa. So we've tried to have different profiles. So we have different nationals, and we have the whole representativity of domes. So we don't have the other Polynesia, so we've stayed centered on the domes. So I've tried, next slide, I've tried to do a slide per topic. So most people who worked on this have said that they really didn't know what that could be, or they had a conviction. And they had questions, different ethical questions. So they had ethical dilemmas, and they struggled to formalize. There was a lack of resources. They hadn't been trained. Laurent Chambaud has said this as well. But on the other hand, they didn't have the instruments, and that's why we wanted to have people who were creating while we're in reflection, because they didn't know the tools, which for most of them, a lot of our experts don't speak English, and so they won't see that. So it's good that there was this parallel approach as well, with a broader thinking process, with people trying to put something in place and tools that are accessible as well. There are even experts who wondered in France, do we truly know what public health is? So is there a domination of what we call biostatistics and epidemiology? In public health, it's not that it's not just evidence-based medicine. There are other types of medicine. There's experiential data as well, which have different types of social sciences as well. I can see Jean-Claude looking at his clock. I won't be I won't try to go over. So a bottom-up approach, which is something that was highlighted massively. So there's no point talking about values, value frameworks. Essentially, we need to start from the basics, the real needs of these actors, of their actual cost questioning as well, to get to the values. Most experts, non-professional ethics professionals, take refuge between biomedical, and for them to talk about ethics in public health, we have to redefine what public health is, and we have to be as close as possible to their work and the questions that they might have. It's a circular approach. We've seen this, so it's something which doesn't transcend. It's very pragmatic, and it's something that emanates from their practice.
Implement public health thinking. There needs to be a backup unit, as was done elsewhere in Europe. There was a strategic thinking unit where the actors could withdraw to. They could call Laetitia, and in some ways has a negative etiquette. We have to group the local thinking groups, which are dynamic, with feedback, and that the developments in the field could develop tangible tools. Next slide, please. Now, it's difficult to create a summary, but now the conditions, the prior conditions for there to be a sort of an ethical dimension in the decision-making process, what runs counter to have a top-down approach. There needs to be willingness from the managers. They need to provide impetus from the top. There really needs to be willingness. There needs to be momentum imparted from the top, and now there's a difference that we've been able to see. Some seek to try a sort of ethics approach, which is a bit like the biomedical approach to strategy, and it becomes complicated. But those in favour of creating of a special committee, and but you might get norms, legislative frameworks for medical legal problems, and others who say no, there's not that kind of accompaniment we need. We'd have a mediation. We have to free ourselves from any too coercive or legislative environment to be able to promote mediation or accompaniment of actors, which doesn't mean we have to go surveys, that we have to answer questions. There are more in-field accompaniment or stewardship in the field. From now, what we're taking is a particular field. We're taking environmental health here, and what was complicated here is a form of ethics has emerged. Now, in environmental health, they're not particularly visible for epidemiology. It might take a few years. There is no evidence-based approach. We don't really know whether problems linked up to over incidence of cancer or prostate cancer, but there's this ability to look ahead and think ahead, to anticipate. We know that something's happening in the environment. It could be severe. There might be a situation of there might be an explosion in some cases, but there is this longer-term cycle there's a repeated exposure. I'm thinking to gases or other cases. We haven't got medical proof in epidemiological terms. We don't quite know what will happen in the medium long term. That's why we have to monitoring missions. So many experts who work in environmentally, we identify things, we can't find a degree of significance or degree of statistical significance that means that things that will happen. So it does create a little problem. There's this overall overarching vision we talked about this morning, that public health is not just health, it's intersectoral. It calls all swathes of the economy and society. And if you give them a health as a remit, but they have to do with policies which go well beyond purely the health domain. Next slide, please. Now, we also know that this work group looked at the uncertainties and what appears to be flagrant. There's a willingness amongst experts to have transparency. Of course, we want to have transparency, but how should you actually organize it? But how to communicate to the fact that there's an old adage, certainty is always reassuring in the simple. But in fact, the state and the people that expect uncertainty, they expect for like something COVID, they expect clear, unambiguous indicators, but it's not as easy as that. And how can we get it across to people, to non-scientific people, that scientific concepts are maybe limited in time with an historical growth, and how can we get that across to people with no scientific background? Well, you need mediation, how to accompany communication campaigns. That would have been better with COVID, with the volunteer sector. We're not involved in the COVID communication campaign, so it's created a degree of confusion and has made fear with regard to the uncertainty and to the lack of real data information on what to do with following the contradictory messages one was receiving. But I think mediation, you can perhaps focus on the most peripheral groups or the most vulnerable population groups. And when it's the groups on the periphery which are normally the most excluded, particularly when the changes take place. Now, there's been a major debate between those of some old vision of the situation, and you just have to ask people what they think so as to improve the accessibility of a given policy. But that's not good. For health democracy, we need to hybridization knowledge. We have to include people into the processes which create action. We have to bring in people, bring them aboard. And those who think that the involvement is just to improve the acceptability of politics, the fact that they say it's not acceptability, it's not buying, it's the sharing of the knowledge, and it's hybridization knowledge. And that's what we call, it's what we call in health democracy, the prior training required for various population groups, improving their ability to understand the subjects that we're going to tackle. Participation is not consulting people, do you like this or not? Should we do this or should we that? Next slide, please. Now I need to get towards the conclusion. Social and local health equalities, social equality, local regional health equalities, and social justice. And this is not really highlighted, but things are very centralized in France. Regarding social justice, it goes well beyond the question of access to healthcare or healthcare reimbursement. But get to it's enabling people to get more access you have to think about financial, cultural, and economic resources that you may have to better use the healthcare system. Now, there was a point where we shared that the experts who were based in the region, there's a feeling that people in the regions, they feel that health policies are very centralized and framed or imposed by rich people, and that they receive campaigns which are not necessarily to the problems they're dealing with. And we all agree that the promotion of health can be, in certain regards, coercive here. Whether people buy into it or not, to use measures or psychosocial models to try and get their behavior to change. Now, there's the problem when we intervene with a given group. You might think that one's action is deleterious or negative for another group or for the environment. We worked on given problems. We tried to work with the suppliers, and it was an ethical dilemma. Some groups of the population, how to overcome rules drafted in France, which are becoming more and more demanding in time of bioethical methods, particularly in cross-border contexts, for example in Europe, or what about in the Comoros Islands, or rules which are not applied on the other side of the border. It's very difficult, therefore, to act where a document might be accepted not in France, but maybe accepted in Brazil. Next slide, please. Transparency is a key principle of public health communication. And we've identified the key obstacles here. Do we have to be completely transparent? We all went through the COVID controversy and the call into question of certain scientific data. And there's a difficulty in organizing ourselves, in organizing training when it comes to reactivity of the social networks. The slightest word, the merest word, is weighed and assessed. And we have to be reactive to prevent sort of social media files from spreading as a result. A few words to wrap up. I've had a lot of texts which came in through, but there is really a need. People who are not ethical experts find themselves having to deal with ethical matters alone. Say with France, we have ethical problems. There are many forms of resource that we can draw on here, but we think it's an approach which is very useful. What I found, because it was creating a strong expectation, everyone to be invited to the seminar. Will they be providing feedback, as we said? But it seemed I'm speaking on behalf of the ethics professionals, and for some of them it seemed completely innovative. But I had people saying I need to make several telephone calls so I convince the right people to come to the meeting, to the conference. But we said it's your opinion that counts. I think I've been working in public health for 40 years. I've really committed myself because I think it's something quite original and innovative and interesting. Thank you very much.